Thank you very much. Thanks for that welcome, and sorry for leaving that little gap when I know you think, is he going to turn his camera on? Is he going to turn his microphone on? Is it going to happen? But that was a wonderful talk just now from Dr. Rake. Really super talk on COVID and neurology, and also it's been a great meeting so far. I must confess, I did not get up at 6 o'clock in the morning to see the very first talks. But it's great the way you've done it, and congratulations on pulling all this together. So I'll start sharing my screen now in a second. There we are. Just one sec. There's always a little bit of a pause, isn't there, whilst we sort these things out. Here we go. Let's just share my screen. Good. Now, hopefully you'll be seeing my first slide in a second. And if I get rid of that and I go slide, present a view. So are you seeing one slide?
We are seeing one slide and your next slide.
Okay, that's right. That's right. Hang on a sec. Let's get that the right way. Actually, just give me 1 second. I'm just going to plug that in because that will work better for me. So
if you can you see my cursor? If you click the presentation at the
okay.
right bottom.
Stop sharing and I'll share it again. It's just to make sure that I'm sharing the right thing. So let's try that again. So I think if I go like that, and then like that, and then like that. Oh, that's the wrong thing. You'd think I'd know. I've done so many of these meetings. Let's just get that.
We pretty much live on Zoom now.
Okay, we're still on Zoom. That's good. Right, let me try again. Share screen. It's that one. That's the one I want to share. Okay. So hopefully you're now seeing something. And if I click that, are you seeing one slide or lots of slides?
We are seeing one slide.
We're in business. Great.
Yes.
Okay. Thank you. Thanks very much for that. Great. And so here we go. I just must start off with some disclosures. So I sit on a few UK advisory committees, including the one that is advising on vaccines. In fact, ours was the committee that the American equivalent said we'd rushed it. We'd done a rush job and we got the Pfizer vaccine through too quickly. And that was because it was a rush job. And then 3 months later, the American equivalent committee also approved the Pfizer vaccine. So anyway, I sit on the vaccine approval committee and also other UK committees. But anything I'm sharing with you today is not, it won't be anything confidential. So I should just let you know that. Also, I appreciate that today's audience is a mixture. I understand that about 2/3 of people are patients or patient representatives, etc. And what I really wanted to do was just to start off and ask you all to just say in the chat function, just to say hello and to let me know maybe what your interest is, whether you're a patient or a family member or whether you're a professional. And then I'll have a better idea of who's there. So just type your answers now in the chat function and we can keep an eye on that as we go along. I also really wanted to congratulate this group of societies for coming together to form the World Encephalitis Day Alliance. I think you've done a great job, and it really is so strong when different organizations pull together like this. And you know, the sum is so much greater than the parts. So I want to congratulate you all on that. And then I also want to congratulate the award winners. I may not have spelt everyone's name correctly. I think I have. Alana Yee, Ben Michael, who is a colleague of mine in Liverpool, and Domingo Esquerdo, who I also know. And thanks very much for that really wonderful presentation on Wendy Station. I didn't meet her, but clearly she was a phenomenal woman and so much of the work, and it was really lovely to see that. And I should also let you know, so good, some people are typing in the chat function and saying hello and where they're from. And I kind of want this to be a little bit of a conversation, because firstly, more or less everything I had to say, Dr. Reiki has said, and put it very nicely. And so what I thought, but there were more questions, and there are questions. And so if people post questions along the way, then what we can do is we'll have a couple of breaks along the way, and we'll just thing that's not clear, and talk to anyone. I must also show you, you're thinking, why is he sitting there in his pajamas? It's not my pajamas, look, it's my World Encephalitis Day t-shirt. I put it on.
Awesome.
Great. And I've asked Becky and indeed one or two other of the core team to leave their videos on, because it's always helpful if you're talking to see people. Otherwise you're just talking to a blank screen, which is not so much fun. So I've asked a couple of the guys to leave their cameras on if they want to, and then that kind of helps me know that there they are. Good. And that means I know that, you know, that we're making good progress. And like I said, do say hello in the chat function. And if there's any questions or comments, we'll try and deal with some of those as we go along. And I can see who we've got. We've got Jessie, who's a mother. That's great. Holly is a patient with working with HESA. So it's really nice to know a little bit about, we've got professionals, we've got caregivers. Fantastic. Okay. All right, well, let's get started. The other thing I should say, you probably saw a slide there back one or two saying I'm tired. So I am tired. And I have modified my presentation a little bit along the way to try and cover some of the things that Dr. Reiki didn't, and to try and answer some of the questions. So it's going to be slightly messy and untidy, and forgive me for that, but hopefully it will still be interesting and informative. So I'm going to talk a bit about different types of brain infection, just to check we're all on the same page. And then about some of our research on COVID neurological disease, some of which Dr. Raki presented just now, actually. We'll talk about the clinical syndromes associated with COVID-19 and think a bit about whether they are, the virus is the cause of them, or indeed, is there just a coincidence? And then a bit about managing and diagnosing, treatment. And then finally, I've just thrown a few slides together, literally as you were starting to ask those questions about some of the long haulers. So it will be messy, it will be untidy, and I'm apologizing for that in advance, but hopefully with your help and with some interaction, it will still be a worthwhile time to spend together. Okay, so the brain, as you all know, is this beautiful thing here. You're familiar with encephalitis, which is inflammation and swelling of the brain substance itself, usually caused by a virus or by the body's immune defenses, such as autoimmune encephalitis. And then we have these other things less of concern today: meningitis, abscess, myelitis, we heard a little bit about earlier, which is damage in the spinal cord. And then we have other presentations where people present just with a slow, long mental or cognitive problem, which is dementia. And there's a range of pathogens that can affect the nervous system. In terms of encephalitis, we mostly think of viruses which enter cells and cause inflammatory damage, but actually some bacteria can also enter the cell and can similarly cause an encephalitis type problem. And I'm going to remind myself to try and use the English language as much as possible, and not to use too many lay terms. So Maddie, your job today is, if I'm saying something and it's a term that I'm Julia, but people can't understand, I want you to shake and wave your arms like that, and then I'll know and go back. Okay, great, good stuff. Okay, so this is quite important. And was it Michael, Dr. Raki's name? What was his first name? It is Michael, yeah. So he mentioned this along the way as well. We have to, definitions are so important, so that we all know what we're talking about, and we're talking about the same thing. So encephalitis is the inflammation or swelling of the brain, like we've talked about. And really the only way you truly know that is by doing a biopsy. And that, originally people said you had to look at brain tissue to see inflammation there. And what do we mean by inflammation? If I scratch my arm and it becomes infected, it goes red and angry and inflamed, and that's inflammation. And of course, in encephalitis, we've got similar red, angry, inflamed tissue in the brain. Encephalopathy is just, it's about what the whole patient looks like. And that is a syndrome of altered mental status, meaning somebody's confused or drowsy or has strange behavior or altered personality. And so one of the most important causes of presenting of patients coming to you with confusion is that they have encephalitis, but there are lots of other causes as I've listed there. And it's quite important that we distinguish between the two. And then the other thing to say is that although encephalitis used to be diagnosed by at tissue by doing a brain biopsy or looking at autopsy material, obviously we can't do that with many of our patients. So we use surrogate clinical markers. And that might mean that we look at inflammation. Oh, good, waving. Surrogate clinical markers. What on earth does that mean? God, I love it. I like this. I think we're going to have fun today. A clinical marker means we look for something else because we're not going to do a biopsy on everybody, okay? And so we look for an alternative marker. It's an alternative clue that the patient has brain inflammation. And one of these is we look at cells in the spinal fluid. So the spinal fluid should normally only have a few cells in it. But if we see hundreds of cells there, that's because the cells that were making the red inflamed bit of brain tissue have spilled over into the spinal fluid. And we see them there. And then we say, okay, that's a marker of brain inflammation. If you can think of a better word for surrogate, give me another word for surrogate. Someone type one in the chat. Okay. And I can see somebody's made a note of ataxia. So I guess Becky will keep an eye on the chat and we'll come back to make a note of all the things people want to talk about. Okay. So I'm a neurologist. I work at the Walton Neuro Centre in Liverpool. And I work a lot on infections of the brain. For 7 years, I was head of the Institute of Infection and Global Health. And my research group is the Brain Infections Group, which we have about 30 members now. You can see some of the senior people here, including Ben Michael, who just won this award. And we started our work in 2003. Actually, Becky, are you in Texas now? I know somebody said they were in Texas. Is that Becky?
Yes, I am.
Where is it? Are you in Houston?
I'm in the Dallas area. Just
Dallas area, okay, because when I started the group in Liverpool in 2003, but from 2001 to 2003, I was actually in Galveston at the University of Texas Medical Branch in Galveston, which is a fantastic place. And that's where I learned my virology. And then I came back to Liverpool. We set up the research group. We set up the Neurological Infectious Disease Clinic and also the course, which you heard mention of earlier. In the UK, we study our brain infections through a network of hospitals who all contribute patients. And you can see them here. It's about 70 hospitals. We also have a network of hospitals that we collaborate with internationally. And we've been doing this. I first worked overseas in 1994 in Vietnam, and we've kept links with many of our Asian colleagues and with many of our other collaborators around the world. And we put this team together as Brain Infections Global. So basically, I'm the director of these three organizations which all work together. So Brain Infections UK, which is our UK work, Brain Infections Global, which is our global brain infection research. And then this awfully named thing that Becky had a great go at spelling out, the NIHR, the National Institute for Health Research, Health Protection Research Unit in Emerging and Zoonotic Infections. I didn't give it that name. It's a national body that I'm the director of. And basically we work on emerging infections. So we were very involved with Ebola a few years back, and then Zika. We've done a lot of work on that. And most recently, of course, on COVID-19. And so because of the HPRU, the Emerging Infections Unit, we take a great interest in any emerging infection problems around the world. So the first I knew of this SARS-CoV-2, as we now call it, was from somebody who contacted me at the end of December 2019, who worked in China. And so we were watching it very closely. I actually, in January 2020, I was here in, does anyone want to have a guess at where this is? Have a go in the chat. Which country do you think this is? Zambia is close. Go on, keep going. I know there's 62 people there. I want to see 62 in Africa. Kenya is close. You guys are close. Mozambique is close. You're all the way around. If I tell you it has a lake, look, you can see that beautiful lake. It's East Africa. It's actually Malawi. So we were in Malawi, where we have a big program. And on the last day, to reward the people who've been doing all the work, we went on a trip upriver. But I spent most of the trip on the phone to my colleagues in Liverpool, who were monitoring the situation closely and said, you know, what should we get ourselves ready for this new virus. And in fact, the guy here with the beard, a friend and colleague of mine, Callum Semple, who was in the UK, and we decided to activate this program, which is like a sleeping giant. So it's called Zoonotic. Callum leads it in the UK, and it's a protocol that allows us to study emerging infection problems as soon as they arise. So we very quickly activated the protocol in all the hospitals across the UK. There's another colleague, Lance Turtle, bringing a sample over from our hospital in Liverpool. And this Zoonotic study has been one of the main studies in the UK, and it's produced some really important. So what it did was, as I said, studying 70 hospitals across the UK, and that meant that we could study many hospitalized patients with COVID-19 as they came into hospital. We've now studied about 170,000. It's the largest clinical study anywhere in the world, and it supported lots of other UK studies, such as one on the post-hospitalization problems. We might come to that when we think about long COVID, genetics, looking at the virus, looking at the immunology, and then here, most importantly, study, which is looking at the brain. And this is led by Ben Michael, who we were talking about earlier. And then there's a load of other studies that we're supporting that I'm not going to say too much about. But one of my co-directors of the Health Protection Research Unit is a guy called Peter Horby, who has led a recovery trial, which is a trial of treatments for COVID-19. And this is the one that showed that dexamethasone reduces deaths by about 30% in hospitalized COVID-19 patients. He told me, so in the morning he was unveiling the results of the study, and by the afternoon he was in 10 Downing Street. There he is, next to our Prime Minister. He wasn't expecting to end up there at the end of the day, and he had to borrow a tie. But this is the study that means now that everybody who comes into hospital with COVID-19 has dexamethasone, and that's reduced the mortality by about a third. But it's these kind of big national studies that are really able to move the whole story forward. This is one of our first publications on the big national study with 20,000 patients, and that's a more recent one predicting mortality. So clearly, if you can identify who the patients who are likely to die, you know who to pay most attention to. And this is just a slide of data from our first study of 20,000 patients. And you can see that right from the start, it was clear these are hospitalized patients, that fatigue was important, confusion was important. These are in the presenting problems of the patients. Headache was important. Some were having seizures as well. And also that comorbidity means other health problems that people have. You can see dementia and chronic neurological disorders were important among those hospitalized with COVID-19. And Michael talked a little bit earlier about some of the existing neurological problems where COVID-19 is having an impact. So what this tells us is that about 70% of hospitalized patients with COVID-19 have neurological symptoms or one symptom, and 10% of them. So a neurological symptom might just be a headache. Now that does not mean they have a neurological diagnosis. It might just be part of their febrile illness. But 10% of them do have a neurological syndrome, such as encephalopathy, a definite neurological problem. And then about 1% of them have a specific diagnosis made, such as a stroke. So in the UK, we had this coronerve study, which I mentioned Ben was leading, many partners involved. And this gave us a good flavour of some of the early pattern of the neurological problems. And we published this in the summer in Lancet Psychiatry. And what we did was doctors, it was just a surveillance, but doctors could report any patients with neurological or neuropsychiatric problems. And then we assessed what they had. And you can see there that the red dots on the left are the patients in our coronerve study. The blue line is the total number of hospitalized patients. You can see the two went up in parallel. And these are the types of patients that we had. And the writing is a bit small, so but hopefully you can see on the left end we had lots of different types of strokes. In the middle we have patients with this altered mental status, encephalopathy, and then more towards the right we have peripheral nerve disorders, and then at the extreme right other nerve disorders. And if I just magnify the bit in the middle, which is those with altered mental, sorry, that's just amplifying the important messages there, those four important groups. And this is another way of looking at it in terms of the age distributions. And you can see there's a slightly different pattern. So stroke that we heard about from Michael is more, it peaks sort of at the 70 to 80-year-olds, whereas the neuropsychiatric, there's a young group with them and an older group with them. So that was the UK picture. We then wanted to look more globally. And so we pooled data from our patients and from published patients all around the world. And basically we reviewed all the literature. And in this literature, this is in the middle of the summer last year, there are 900 patients altogether. The common things that were being reported were encephalopathy, which is this altered consciousness, encephalitis specifically, and then Guillain-Barre syndrome. And Guillain-Barre syndrome is something we must come back to at the end. And then also, as we heard, anosmia, lack of smell, and ageusia, lack of taste, were common. And stroke was also common in hospitalized patients. This shows you some of the imaging changes. Top left there are the changes of encephalitis. This is broadly similar to a patient with herpes encephalitis. So it's the mesial temporal lobe. I haven't got my brain with me today. I usually have a plastic brain, but the temporal lobe is tucked deep inside the brain, and it's the middle part of that where there is some inflammation. Then ENF is a patient with a stroke. Actually, you can probably see my arrow if I put my arrow there, I think. And C and D is a patient with this rare but quite characteristic necrotizing encephalopathy. So one of the challenges we've had, I think one of the challenges we all have, is just as Tedros said, the WHO director, we're not just fighting a pandemic, we're fighting an infodemic. So much information coming at us all the time. And some of this is accurate, some of it's not. It makes it harder to really find out what's going on and make sense of things. And so this infodemic has, there's various aspects to it. In my profession, we write up our research results, we publish them. In the past, these have always had peer review before they get published. So colleagues look at them, criticize, suggest changes. But now we are all publishing our results directly without peer review. It then gets peer reviewed and published in a journal. But people putting stuff out there, it's good because it means there are no delays. But the downside is it means nobody's checking that what you say makes sense. Then, of course, there's all the social media stuff as well, and many people are using that as a way of getting information across. That just shows you publications increases, don't need to worry about that. Now, many years ago, somebody called Austin Bradford Hill came up with these criteria to define causality. And what this is all about, we see one thing is associated with another. Let's say Guillain-Barre syndrome seems to be associated with COVID-19 because we're seeing lots of patients who have, lots of patients have COVID-19, and then Guillain-Barre syndrome, which I better just explain. I think it was mentioned earlier, but whereas encephalitis is inflammation and swelling in the brain, in Guillain-Barre syndrome, it's a similar problem in the peripheral nerves. So the nerves that go from your spinal cord down your arms and legs. And that's what Guillain-Barre syndrome is, inflammation there. But just because two things seem to be occurring together, it doesn't necessarily mean that one has caused the other. And let me give you a nice example of this before I tell you about the Bradford Hill criteria. Every winter, we see lots more flu virus, okay? We see lots of patients with flu virus. So if you look at the flu virus figures, there's a lot. But also every winter, we find lots of patients come to hospital with fractured hips, okay? And including lots of patients with fractured hips who also happen to be infected with the flu virus. But of course, it's not the flu virus that's caused them to fall over and fracture their hips. It's the ice on the ground, yeah? So it's icy in the winter, people slip, they fracture their hips. In the winter, you also tend to have flu viruses circulating, but it doesn't mean the flu virus has caused the fractured hip. Now I think you're getting that because you're nodding, which is good. I only thought of that about 10 minutes ago. But it makes the point that just because two things are happening at the same time and even in the same patient, it doesn't mean one has caused the other. And the Bradford Hill criteria, which I won't go through, are basically a very posh way of saying what I've just said. You can see he's wearing a bow tie and I'm wearing a t-shirt. But it's basically the same thing. So, and we need to bear that in mind because of all the various things that are being reported. So let's move on. We one thing I guess our group has always done in the 20 years or so we've been operating is always try and be very precise about clarifying, using case definitions to define precisely what we mean. So we produce these case definitions for different neurological syndromes in COVID-19, and these are now being used by many people around the world. We published them in Lancet, we published them on the website. They're in the WHO criteria that Michael mentioned earlier, with some modifications. And then also through our brain infections global group, we decided to get together lots of data from lots of patients around the world. So again, this is an open resource. We shared our case definitions with everybody, and then we said, look, why don't you share your data with us on any patients that you're seeing? And these are the case record forms. We don't need to worry too much about that, but we have data now from more than 2,000 patients with neurological associated COVID problems from 78 countries, and we're analysing these data at the moment. I'm going to pause for breath, and also I'm going to pause. Let's just take a moment and see what's coming on the question side, and whether there's anything I've not been clear on, or anything that people want me to pick up on.
Tom, there's one question on a person that had encephalitis in 2018, after her second baby was born, and her mom's sister had brainstem encephalitis 40 years ago. She's been told there is no connection, but she's wondering, is there any evidence of that since she has 2 children?
Yeah, thanks for that question. So, and also, of course, in this part of the world, we say encephalitis. In America, we say encephalitis, but we won't fall out over that. And rhomboencephalitis, again, is actually a posh term for brainstem encephalitis. The rhomboencephalon is the brainstem, which is the stalk on which the brain sits. So it sounds like those 2 people who are related both had a brainstem encephalitis, but I don't know of any hereditary causes of brainstem encephalitis that would cause that 40 years apart. And so it'd be interesting to know what age they were, whether they were at the same age. And I think anyone, whenever anything happens in the family, when 2 people in the family are affected, people are going to be slightly concerned, and think, oh, could this affect somebody else? But there's no medical condition I'm aware of that means that we should be excessively worried about the children in the family. Okay, all right, well.
There was one other question about if there's anything that can be done to help with ataxia.
Yeah, so ataxia is unsteadiness, and I see patients with ataxia. There's a range of different causes. It's a bit like saying encephalopathy. So it's not a specific diagnosis, it's a description of unsteadiness, which can affect people when they're using their limbs or when they're walking. And unfortunately, it's one of those neurological conditions where, tragically, we don't yet have treatments. So what we do, though, when we see patients in clinic, we try to make things as easy for them as possible. And a lot of it is about supporting with rails on the stairs to make sure they don't fall, and providing any other support, physio and occupational therapy like that, as much as we can. All right, well, let's move on, keep moving forward. So I'm going to tell you a little bit more. I'm kind of deciding what I'm going to tell you. It's quite nice. I've got all the slides here and I can decide where we go next. We've heard about stroke, I think, and we've heard about mechanisms of disease. So I won't, there's no point repeating what Michael talked about specifically. Maybe what I will tell you a little bit about, just partly because it's fun, is this difference, and you will have come across this yourselves as patients, where different specialists see things differently. So this is our paper I talked about earlier with neurological, neuropsychiatric complications. And it's quite new, this approach to get the and the neurologists together. They used to be the same specialty. So before Freud, they were just one and the same thing. We have the brain, something's gone wrong with the brain. Let's see what we can do to help. But it was actually Freud. I mean, I'm not an expert on this, and I know you had some you had Tim Nicholson talking earlier, I think, didn't you? So anyway, before Freud, it was all the brain. It was one thing. Post Freud, approximately, things separated, the psychiatrist and the neurologist separated a bit. And that has caused some challenges over the years. And in particular, it's making issues at the moment because of the way we see some of these patients. So after we published one of our patients, some of the psychiatrists kind of got a bit upset because we weren't referring to, we were calling it encephalopathy, they were calling it delirium, etc., etc. And it's basically, it's a little bit of a Humpty Dumpty world. In Humpty Dumpty it says, when I use a word, it means just what I choose it to mean, neither more nor less. And I think the problem is that the psychiatrists and neurologists are to some extent seeing the same thing, and they're just calling it something different, and which is not helpful. So clearly we need a single case definition or set of case definitions that we're all happy with, and we are working on that together. But it's a little bit like, and maybe this is happening quite a lot in SARS, it's the COVID-19, it's the elephant and the blind men. I don't know if you know this parable, but some say it's Chinese, some say it's from India, but basically all these blind men are in the room with an elephant, and because they can't see and they can only feel one bit, they give a completely different description of what they think this animal is. And we're all a bit like that. We all have a tendency to claim absolute truth based on our limited subjective experience, but we have to really move beyond that if we can. So, and as I said, we are working now much more closely, the neurologists and the psychiatrists together, to try and make sense of what we're seeing. What I might do is just talk a bit more about the encephalopathy of COVID-19, because that relates specifically to encephalopathy. So here's quite a nice publication that looked at patients with encephalopathy. They're all intensive care patients, and so at least they tried to take a broader picture. And they intensive care, 118 had an abnormal neurological exam with or without delirium along the way. And this shows you some of the imaging studies and imaging in studying this disease. And you can see there's a mixture of things, at least I can. You can see in white shapes, but I'll talk you through it. I know many of you will have seen scans anyway. The ones, most of the scans, somebody's lying on their back and we're just slicing through their head. They've got their feet close towards us. The head, and there are different modalities being used, different types of scan, but that doesn't matter too much. But what we are seeing is lots of microhemorrhages, tiny, and that's what these little dots are with the arrows pointing at them, tiny little bleeds. And also there are areas where there is more of a diffuse abnormality, like this one you can see down here. It's a white, more diffuse, it's more like a fluffy cotton wool type of pattern. On here again, you can see here that here's the fluffy cotton wool type of pattern. You see this? So can you see can you see my arrow? I don't know if you're seeing my arrow or not. You are. Okay. Well, my arrow there is on normal brain tissue, which is a sort of dark grey. And then when you come inside, you can see like white blobs of cotton wool. Are you seeing those? Yeah. And that's that. So that is it's bleeds. It's not tiny little bleeds. It's a diffuse. It might be fluid in the brain tissue. Okay. And in this study, they found that altered mental status, encephalopathy, was more likely if patients had severe disease. And they saw a mixture of things, tiny dots of hemorrhage, areas of low perfusion. And I think some of it might be related to this cytokine storm, which we heard about earlier. So I think I saw a question on cytokines. So just to explain that, forwards instead of backwards. There we are. So what are cytokines? Well, when you get any kind of infection, your body fights it. And one of the ways it fights it is to produce these chemicals that go around the blood and that just galvanize the immune system generally. It's the cytokines that cause you to have a fever. It's the cytokines that make you feel a bit groggy. And it's the cytokines that galvanize the immune defense system and say, come on, let's do it. Let's fight this infection together. But in SARS-CoV-2, in COVID-19, people are having too much of a good thing. There's too much of that strong cytokine response. And it's actually, it's a bit like a friendly fire incident in a war. it's actually damaging healthy tissue. It's causing people to be confused. So it's too much of a good thing is actually causing damage. So what about the virus itself? I think somebody asked Michael this. It's very rare to find the virus in the spinal fluid. Now, those of you who have had herpes simplex virus encephalitis or a family member will know that the way that was diagnosed was because somebody did a lumbar puncture, tapped off the spinal fluid, and then looked and saw that the virus was there in the spinal fluid. And in COVID-19, however ill people are, however deep their coma, they might be fitting, they might be terribly unwell. We very rarely find the virus in the spinal fluid. It has been seen occasionally at autopsy, but again, this is all pretty rare. So these are some data. I mean, you'll have to forgive me. I'm using slides from previous talks because I've been busy. So I don't think we need to worry too much about the detail here, except to say that what I will show, if you look at E there, E, the brown stain, when we add a specific stain to try and detect virus. And you can see there is some brown staining there. So there was a little bit of virus detected in this patient. But the interesting thing is when we do autopsies on patients who died of COVID-19 and brain problems, what we don't see is this pattern here. And if you look at Japanese encephalitis there, you can see that's a blood vessel. It's pink. And you can see all the blue dots, and those blue dots are the body's white cells trying to fight the infection, and they've spilled out of the blood vessel into the brain tissue, and they're trying to fight the infection. And it's those white cells that cause that inflammation, that angry redness that we see. So we see it in Japanese encephalitis, we see it in herpes simplex virus encephalitis. So it's white cells spilling over into the brain to cause inflammation. But when we look in SARS-CoV-2 infection in COVID-19, we don't really see quite the same pattern of strong inflammation. All right, well, I'm going to pause for breath and tell you now, change tack slightly. So one way we look and try and understand what's going on with patients is in those who've sadly died, we look at the brain at autopsy. The other way is we do brain imaging. That's in people who are alive. Obviously, that's very informative. But it's very hard to look at the brain in people who are to actually look at the brain in detail in people who are still alive. Obviously, you can't do autopsies. We do brain biopsies sometimes in people. I don't think that's been done in SARS-CoV-2 very much. But what we have been able to do is look at the nose, and the nose is giving us some clues on what may be happening in the brain. This is my daughter Eva, who was the first in our family to get COVID-19 many months ago, and she lost her sense of smell. And this is a very common problem in COVID-19 infection. And it turns out this is a really elegant paper, which you don't need to worry about at all, the details. It's just to remind me to talk to you about it. And it turns out that the virus is not going into nerve cells itself. It's not damaging nerve cells, which is what happens in herpes encephalitis, in Japanese encephalitis. Virus goes into the nerves, it reproduces in those nerve cells, it destroys nerve cells. What we find in SARS-CoV-2 in the nose is that the virus is going into not the nerve cells, but the, we call them supporting cells. So if you imagine, here's a nerve, imagine this is my nose, here's a nerve cell coming here, and this is fresh air. And so the nice smells come up into my nose and I can smell them by detecting them here. This is my nerve cell, and then it sends signals to the brain saying, lovely Chinese food. So you have the nerve cells, then you have lots of cells all around the nerve cells which are supporting it and providing nourishment and holding the structure in place. And it's these supporting cells that are actually getting infected. And what that means is, because the supporting cells are infected and damaged, the neuron is not working properly, and that's why I lose my sense of smell. But what that also means is that it will recover, and as these cells get better, my sense of smell recovers. Whereas when nerve cells, when neurons are infected and damaged, they usually don't recover. And so the nerve is telling us quite a lot about what might be happening in the brain. There's a lovely picture that we don't need to worry about too much at the moment, but this I will show you. So what has happened here, this is a brain scan, and in this picture, if it's me, I've been sliced right through the head there. And these two blobs there are the olfactory bulbs. So if you like, I must show you here, I'm pointing to the wrong arrows. So this space here is just fresh air. And those two things, if you like, they're almost big nerves pointing down. And those have got swollen and damaged, but they will get better. And you can see they got better there in this patient after some time. Okay, so that's the nose. So what do we think is altogether when these patients are getting altered consciousness encephalopathy? We think there are three different things going on. There's, in green is the nerve, and you can see the nerve, these are the viruses, the green blobs with spikes on. So virus is coming in, okay? It's not actually infecting itself. That's a pretty rare occurrence. But virus does sometimes, this is a blood vessel, and virus sometimes infects the lining of the blood vessel, and you can see it. Are you seeing my arrow? Yeah. So it affects the lining of the blood vessels, and that makes blood vessels leaky, and then fluid can leak out. And we saw that fluid on some of the brain scans earlier. And then the other thing the virus does is it activates the clotting system. If I cut my arm now, it will bleed, and then it will stop bleeding, and it's the clotting system that stops it. But somehow the virus actually activates the clotting system, even though you're not bleeding. And that then makes a clot, and the clot blocks a blood vessel, and that's effectively what a stroke is. So we think those are the most common mechanisms. And the other one is just this general cytokine activation that Michael talked about and that I talked about earlier. So I'm going to just flick now to some slides that I threw together towards the end, but just to cover some of the other things that came up that I thought people might be interested in.
Tom, do you mind if we break for a couple of questions?
Very good idea. Perfect. Let's do that.
Okay. We have somebody that's an encephalitis survivor and is wondering if there's any studies that have been conducted about patients followed who have had encephalitis and then contracted COVID-19 later, and the effects on their brains and their bodies.
Of course, everyone connected with this meeting today is already somebody who's in some way been affected by encephalitis. So this is somebody who's had encephalitis, and they're saying, if I now get COVID-19, how might it affect me? That's more or less what they're asking. Yeah. I'm not aware of any major series of patients like this. My patients who've had encephalitis, I reassure them that unlike some previous illnesses, which are definitely associated with an increased risk of getting COVID-19 and an increased risk of severe disease, encephalitis does not seem to be one of those. So, we know if you have diabetes, or if you're overweight, or if you're from a Black or Asia or minority ethnic group, you're at increased risk of severe COVID-19. And we know that if you've had so your severe immunosuppression because of an organ transplant, you're at increased risk. But there are many other illnesses that don't seem to be particularly increased risk, and that encephalitis is in that basket. So I say be careful, but there's no particular risk as far as we know.
That's good to know. Okay. Earlier when you were talking about the distinction between encephalitis and encephalopathy. Somebody has a question about seronegative encephalitis with no abnormal MRI, no abnormal EEG, no abnormal PET scan, nothing in the CSF. Her daughter was initially diagnosed with subacute encephalopathy, but other doctors now are calling it autoimmune encephalitis. Would it be more accurate to call it encephalopathy or encephalitis?
Jesse, it's Jesse, I can see. That's a great question. Thanks very much for asking about it. And so it depends. It's all about the case definition, how you define it. And so we, in the past, have said to call it encephalitis, you have to have some evidence of this inflammation. And that might be cells in the spinal fluid, or it might be swelling on the brain scan. But you're right, if somebody's got altered consciousness, but there's nothing to tell you that there's inflammation, then you would call it, or I would call it, an encephalopathy. Now, there's a caveat, there's a catch, which is, let's say somebody has encephalopathy like that, but we then find they have autoantibodies like NMDA antibodies that we know are strongly associated with this illness called NMDA encephalitis. Then we're sort of slightly stuck, because we're saying clinically they have an encephalopathy, but we've detected this antibody which is associated with encephalitis. So some would then want to call it NMDA encephalitis, even though we've not got the clinical evidence for encephalitis. I would say it's an encephalopathy associated with NMDA, but I think your daughters had no antibody detected. So I would probably call it somebody's called it a seronegative encephalitis. I'd call it a seronegative encephalopathy.
Okay, thank you. And we have a ton of questions. I don't know how many slides you have left, so is it better to resume, or do we do questions?
No, let's do the questions, because I've got not too many slides, and I think what people want to know.
Okay, all right. Another question is, if you're receiving Rituxan, is the COVID vaccine effective?
Good question. I'm being distracted by another question. So as far as we know, it is effective. It is effective. These are hard questions to answer, in the sense that in the original trials, people with other illnesses and on other drugs tend not to be in the trials. But we would certainly recommend getting vaccination, even if you are on a drug like rituximab.
Okay. And some folks that have had encephalitis have tinnitus. Do you connect the two together?
Yes, so tinnitus or tinnitus, as I call it, is ringing in the ears, and you do sometimes in a patient, but it's not particularly a complication of encephalitis. So it's a bit like the having flu and having a fractured hip. These things can be a coincidence and not necessarily one causing the other.
Okay. And one person has a 23-year-old daughter that recovered from anti-NMDA with intrathecal rituximab, and she's now in medical school. They are asking if it's safe for her to get the COVID-19 vaccine.
Yeah, I think so. And I mean, always, obviously, we're in the kind of setting, I should have said at the start, but it's almost taken for granted. You have to check things with your own healthcare providers and doctors, and so everything I say comes with a health warning. But I don't want to sit here. It's not helpful when somebody says, "Oh, I'm not going to tell you, you might sue me." So as long as you promise not to sue me, I'll keep giving my best answers.
All right.
That question, let me just go back to the question about the tinnitus. So I've got a couple of slides that relate to this issue that I just thought I'd show you because it's interesting. So the Guillain-Barre syndrome I mentioned is this problem with nerve damage. And this slide shows you the very first report of Guillain-Barre in COVID-19. Neurologists love Guillain-Barre. Doctors seem to love Guillain-Barre. I don't know why, but they absolutely love reporting on it. I think it's because it's kind of crisp and clear. I mean, those of us working in the world of encephalitis, encephalopathy, you've seen even today from the questions, it's slightly murky, but people love GBS because it's pretty crisp and clear. So there's the first report. Then we have, when we did our review, there were 19 patients had been published by July 2020. I checked just half an hour ago, there were 75 different publications on Guillain-Barre and COVID-19, and these publications, have many patients within them. So the temptation is to think, well, of course, COVID-19 must be causing Guillain-Barre. These are all patients who had Guillain-Barre. They all had COVID-19 infection, but there's so much virus around anyway, and Guillain-Barre syndrome happens anyway. Could it be a coincidence? And there's my flu and fractured hips. So friends and colleagues of mine have looked at this now in the UK. And since the start of the COVID-19 pandemic, they've looked at where all the GBS, Guillain-Barre syndrome, and all the COVID-19. And you can see that if we look, well, they don't map up. So these are the areas where you've had a lot of COVID-19 in the north of England. And yet down here in the south of England is where you've had a lot of Guillain-Barre syndrome. It doesn't tie up. And then the next thing they did, which was even smarter, was they looked year on year. So first of all, if you look at the along the bottom of the months of the year, And if you look at that wiggly line, that's the number of COVID-19 cases in the UK. And then if you look at the coloured bars, they're showing you the different years. So the red coloured bar is 2020, and the other coloured bars are the preceding 5 years. And what you can see, it doesn't matter what time of year it is, basically once the COVID-19 pandemic started, we're not seeing more Guillain-Barre syndrome, we're actually seeing less Guillain-Barre syndrome than we do normally. So rather than being increased, we're seeing a decrease. And we think the reason for the decrease is because Guillain-Barre syndrome is triggered by a range of infections, and many of the other infections have not been passed on because everybody's in lockdown and isolation. Anyway, so that makes the point, I think, about cause and coincidence. Are there any other questions?
Yes, there are. One person was asking if there was anything to help with ataxia.
Yeah, so actually, I think we had the ataxia question, and that was where we talked about the fact that there are many causes, and unfortunately, there's no specific treatment yet.
Okay.
Somebody mentioned long COVID earlier. So what I think I might do is I'll just show you a few slides on this, and then I'll pause whilst there's any other questions. And whilst we pause, I'm just going to disconnect and reconnect my screen, because I wanted to show you a little video at the end. But let's just talk about long COVID or COVID long haulers. This is Google Trends. You can see on February 23rd, 2020, this expression did not exist. Nobody was looking for it. And as the months have gone on and on and on, there's been more and more searches on Google, which means probably, it is something of interest. So, and one of the earliest people to talk about this was a colleague of mine here in Liverpool, Paul Garner, who was at the School of Tropical Medicine. And he got COVID on March 19th. Now, he wasn't hospitalized. He just, it was like a bad flu, but he felt pretty rough with it. But he's had ongoing symptoms months and months and months afterwards. And and he and many others got together. I mean, it's been a great area. It's been really interesting because it's been an area where the patient groups have really led the way. They've come up with this term long COVID. They've said, look, this is something we need to pay attention to. And I think the problem was that people who had COVID at home, and some of them weren't even getting a diagnostic test, the presumption was, well, if you didn't need to come to hospital, it's all mild and you don't really, it's not going to be a problem. But what Paul and many others were saying was, no, we do have a problem. Then you've got people like this guy, Michael Rosen, who is a well-known author. He was the children's laureate in the UK, but well-known author who got very severe COVID. He was in hospital. He was on intensive care for 47 days. And then he came out of it. And, not surprisingly, when somebody's been terribly ill like that, they have ongoing problems. I mean, anyone who's had encephalitis, most people will have ongoing problems for months afterwards. So people like him were coming out saying, oh God, I feel terribly unwell. I've still got these problems. And they were also calling that long COVID. Now, then we're in a bit of a mess because everybody's calling it long COVID or COVID long haulers. And unfortunately, I mean, I mustn't be organizations like the National Institute for Clinical Excellence and the Centers for Disease Control. But unfortunately, I think these guys are a bit behind the curve because they're still not, they're coming out with case definitions that are still not very helpful. So this is it's like the UK CDC, if you like. And they're basically saying anyone with ongoing symptoms beyond 4 weeks, they call it ongoing symptomatic COVID. If it's still there after 12 weeks, they're calling it post-COVID syndrome. The CDC also say symptoms go on. They all avoid, they say patients are calling this long COVID, but the problem is they're not doing anything to distinguish the different types of problem people can have after COVID. So this is in press actually at the moment, something I wrote a few weeks ago. And from the neurological perspective, I think we can think about the long-term effects of COVID-19 as one of three groups. So firstly, there are the sequelae, just means consequences, of people who had an identified neurological complication of the acute infection. So they had COVID, the COVID caused a stroke, and now they've got problems caused by the stroke. So we know that happens. We know strokes leave you with problems. So they need support, but there's no great mystery there. The second group are people who have consequences after a long time in hospital, especially if they've been on intensive care. We know if you're on intensive care for many months, you're going to have cognitive impairment. Your brain is not going to be quite the same, especially as soon as you come out of hospital. Or you're going to have a critical care neuropathy. Your long nerves in your arms and legs get damaged. We know that happens anyway. But the third group are the patients who've had neurological, neuropsychiatric, and indeed other symptoms, lots of other symptoms, which are occurring often in patients who had milder COVID initially. And some of these symptoms are similar to post-viral fatigue or chronic fatigue syndromes. And, you know, we have to distinguish these different groups, otherwise we're going to get nowhere. And personally, I think the third group are the group that really, where we need to do work, because the first two we know about anyway, but it's the third group that need a lot of attention. Somebody did a review of all the symptoms of well, I think they looked at all the publications on long COVID. And what they found was the most common problems were fatigue, as you can see there. Headache was also common, and muscle aches and pains, lots of other non-specific ones. And then this, again, these are pretty well thrown together a bit quickly, so I apologize, they're a bit messy, but I think they do convey important messages. This was really interesting because this was one of those studies done by patients, completely done by the patient organizations through Facebook and the internet. And they did their own survey, 2,000 people from 56 countries, most of them not hospitalized. And that's the important thing. Let's focus on those who were not hospitalized. And these are the most frequent symptoms after 6 months: fatigue, malaise, especially when you do something. And also, sorry, I forgot, very importantly, because I think I have a little bit myself still, the cognitive dysfunction, the brain fog. I had COVID-19 over Christmas, and still 6 weeks out, I'm still not as sharp as I would like to think I should be. The slide there shows you, the graph shows you, some people got better very quickly, and the green line goes down, but the purple line, some of them are still not recovered many months later. And then I think the other thing, I'm treading into potentially difficult territory here. Many of my friends and colleagues just avoid going into these areas because it can be a bit controversial and you can lose friends. But what I will show you is these are the symptoms reported by this patient survey, reported themselves. Again, it's a messy slide, sorry, it's untidy. But in addition to the things that I was talking about, like fatigue, headache, etc., they report other things because they were allowed to report anything they wanted. So 19% of people are reporting visibly inflamed or bulging veins. 20% lots of bowel sensations, floaters in the eyes, changes to the ear canal, brittle or discolored nails. And this is where it gets challenging because some of these are things that doctors, medics traditionally may not recognize as being complications of any disease. So it is a moving space. I'm going to pause there for more questions and stop sharing my screen whilst I just organize myself. And then I've got a 3-minute video to show you at the end.
Great. We have a ton of questions, but based on the time and the video, I'm just going to ask one more. Trying to pick which one. So somebody has had, a relative had herpes virus and post autoimmune encephalitis. He suffers a racing heart at 160 beats. Do you feel like this could possibly be a neurological side effect or severe anxiety or possibly a side effect of medication?
So he's got a racing heart. Did he say how many months out he is?
It doesn't indicate.
Doesn't say, okay. Well, I think these are some of the things that we are seeing in these post-COVID syndromes. So I focus mostly on the brain and the neurological side and the psychiatric side, but clearly there are other symptoms in other parts of the body, and that may well be what we have there. Okay.
Why don't we move? Go ahead.
Yeah, I don't have to show the video. Do you know what? I've misunderstood the program because it's so many. It's the thing I was saying was slightly confusing. I thought I was talking for an hour, which did seem long to me, but I see now, I'm understanding it now. Within that, there's the 15-minute Q&A, but we've done lots of Q&A along the way. So I think we've covered that. Do you want me to stop or to show this, even the start of this little video?
Let's check out the video.
Okay, well, it was really, are you seeing, oh, I need to share again. Bear with everyone, share screen. It should be a bit easier if I do that. This should work. And I do that. So, well, really, I just wanted to, again, congratulate you all on the journey that you've made as an organization. This is my journey with the Encephalitis Society in the UK. And the Encephalitis Society, I came back from, I'd been studying encephalitis in Vietnam from 1994 onwards and got involved with the society. And then in 2014, we had this idea of World Encephalitis Day. And so what I thought I would just show you is this little video here, which because of the internet, it may be too clunky, in which case we'll forget it. But let's see if it works. Are you seeing something that looks like a video?
Yes.
You know what, but schoolboy error. When you go share, you have to share your screen as well. So I'll stop, I'll go share screen. You have to say share sound. Done it now, right? And share that screen and share that and click that and click that.
Didn't know where I was or who I was.
3 weeks old, started to struggle with his breathing, temperature dropped.
Encephalitis. Encephalitis.
I couldn't stand the lights. I couldn't even stand a clink of light. I had total darkness.
Nope, never heard of it.
Imagine being affected by a disease you've never heard of. Encephalitis is inflammation and swelling of the brain, often caused by a virus or by the body's defences.
World Encephalitis Day is about raising awareness about a condition about which little is known.
15.
I am 4.
Encephalitis can affect anyone of any age.
Sierra Leone, Malawi.
It affects people all over the world. To mark the first World Encephalitis Day, we wanted to do something big, really big.
Today we've been over in Liverpool attempting to break the Guinness World Record for the biggest human organ, making a brain out of people.
Patients with encephalitis often have flu-like symptoms, very non-specific symptoms. They may be confused or have very strange behaviour. And it's really important, if they do have any of those symptoms, that doctors would think about brain infections and refer them immediately to the hospital.
The doctors come out, 3 sets of different doctors come out, and the final set thought there was something wrong with it, so they put it into the hospital.
When we get to these patients early with appropriate investigations and appropriate treatments, we can make a dramatic impact on their outcome.
Had about 3 or 4 lumbar punctures to actually get a confirmed diagnosis exactly to what virus it was.
I think I actually would have died. It was a bit of a 50-50. Mum and Dad said it was the worst thing a parent could hear.
Often patients have seizures. A seizure occurs when the brain's electrical activity becomes disorganised. It's like the wires getting crossed. Even with treatment, patients can still be left with problems. Depending on which part of the brain is affected, that determines what type of problem they have. If it's the temporal lobe, then memory is often affected.
When I first came out of hospital, I had problems with my memory. I couldn't remember before the illness or through the period I was in hospital, only what people were telling me.
The cerebellum controls balance, and when that's damaged, people can lose their balance and find it difficult to walk. At Liverpool, we are leading research internationally to try and fight encephalitis.
In Asia, we have been involved in major campaigns vaccinating millions of children against Japanese encephalitis.
For other forms of encephalitis, it's about doctors recognising the disease.
In Africa, where I work, rabies is an important cause of encephalitis.
With the Liverpool Big Brain, we're
I think we lost the sound. Did we lose the sound?
We did, yes. It's probably a good stopping point. It's a great video. Thank you for sharing that. I'm just looking at the time and
that's fine. You get the idea, and it's on the YouTube for anyone who wants to see it. And the other thing I should just direct you to, you mentioned my book earlier on, the Roald Dahl's Marvelous Medicine, and of course this week in the UK, the film about his poor daughter Olivia, who died of measles encephalitis, has come out. So if people want to learn a bit more about that, you can get the book on Amazon. And I should say that the proceeds from the book go to various charities involved in work on the brain.
That's awesome. Well, Tom, as always, it's great listening to you. We appreciate your enlightening presentation as well as answering all these questions. We may send you some others that we didn't get to answer, but this is a great presentation as the pandemic continues, and we appreciate all you're doing to study not just encephalitis, but to work on COVID as well. And thanks for continuing to create awareness. That's so helpful from the medical community. So thanks so much. We appreciate it.
Thanks. Enjoy the rest of the day. I'll be around for the rest of the day anyway. I'm going to keep watching. It looks great. You've got some great talks lined up.